Hello everyone, this side Dr.G and today we are going to discuss about the development of the stomach and the clinical correlation related with it, that is the congenital hypertrophic pyloric stenosis. So let's start. So you already know that we have this foregut, midgut and hindgut. Okay, so let me just draw this. Yes, we have this gut tube, right? This is the gut tube, and yes, the gut tube, it is endodermal in origin, right? It is derived from the endoderm, okay, the yolk sac. So this is the foregut, midgut and hindgut, right? Foregut, midgut and hindgut. So now coming on to the development of the stomach. Development of stomach. So the stomach basically develops from the distal part of the foregut. Okay, it is developing from the distal part of the foregut. Okay, so yes, the lower part of the foregut, it has a fusiform dilatation, right? So let me just draw for you. Now the lower part, I'm taking this portion out, right, and just trying to show you that there is a fusiform dilatation. Okay, a dilatation which is having two tapering ends. Okay, it is having two tapering ends, so it is like this is a fusiform dilatation. Okay, so now the lower portion, so the development of the stomach, it develops from the lower portion of the foregut, or I can say the distal portion. Distal portion of the foregut, between, like it is between fourth and the fifth week, right? It is between fourth and fifth week. Now this fusiform dilatation, okay, initially foregut, it is a simple tube, right? It is a slight dilatation, okay, in the stomach, and this stomach becomes fusiform in shape, right? So this becomes fusiform in shape. So this is the developing stomach, I can say. Developing stomach, right? Now let us just mark the parts over here. The part which is coming in front, it is called as the anterior part, right? This will be the anterior part, right? So the part which is behind, it is called as the posterior part. This part, it will be easy if you mark the parts right now. It will be easier to understand this, right? Now, so you can see there will be a part. Now if I just divide this into like two parts, right? So yes, you can see that one, it is the right part. Okay, this will be the right part of the stomach, and this will be the left part of the stomach. Okay, so we have anterior part, posterior part, right and the left part, right? So now initially, so let us just complete the notes. On the other hand, initially stomach, it is a simple tube. Okay, it is a simple tube. If there is a slight dilatation, what will happen? It will become fusiform in shape. Stomach becomes fusiform in shape. Fusiform in shape. Right? Now, what happens? There is differential growth in the wall of the stomach. There is differential growth in the wall of the stomach. Now, what is happening? The posterior border or the posterior part, which I have highlighted with green. So yes, remember the posterior border basically it grows faster than the anterior border than the anterior border. So the posterior border grows faster than the anterior border. Okay. So now what is happening? What is happening over here? That the anterior border will become the lesser curvature and the posterior border will become the greater curvature in the future, right? It will become the greater curvature in the future, right? So resulting in the anterior border turning into lesser and the posterior border turning into greater curvature. Now let us just take a cross section over here. So you already know that if I just take this part of the stomach, right? Yes, this is the part of the stomach which I am taking right now, right? So you already know that on the sides of this tube, let us suppose this is the right side and this is the left side. On the right side, we have the vagus nerve. Okay, we have the vagus nerve, that is the right vagus nerve, and on the left side, we again have another vagus nerve, that is the left vagus nerve. So yes, this is the right side and this is the left side. So we have the right vagus nerve and the left vagus nerve. So initially it was a tube and you can see this. Now what will happen to this? What will happen to this? There will be something called as the rotation of the stomach which will occur. Rotation of the stomach. Rotation of the stomach. Now rotation of the stomach, it is due to the differential growth of the stomach. It is due to differential growth of the stomach, and also we know that we know that yes, let me just try and explain you. Yes, suppose this is the anterior abdominal wall and this is the posterior abdominal wall. We already know this is the developing stomach, right? This is the developing stomach and towards the anterior abdominal wall. Okay, now, this is the mesentery, which is okay outside the endoderm. If the gut tube, it is the endoderm. So outside the endoderm, what will be present? Yes, it is the mesoderm, and mesoderm, which is connecting the stomach to the anterior abdominal wall. It is called as the ventral mesoderm, or I can simply say it as the ventral mesentery, right? Now, in the ventral mesentery, an organ is developing and that organ it is called as the liver. So rotation of the stomach is one due to the differential growth of the stomach, and the other reason for it is due to the growth of the liver, due to the growth of the liver, due to the growth of the liver, right? So now what will happen? There will be 90-degree rotation, okay, or I can say, yeah, let me just write it over here. So we will have 90-degree clockwise rotation. 90-degree clockwise rotation. Now 90-degree clockwise rotation, okay, what will happen? No, 90-degree clockwise rotation, it is around the longitudinal axis and the transverse axis of the stomach. So it is around longitudinal axis and transverse axis of the stomach, right? So now what will happen? Now what will happen? See, let us just try to show you over here how this rotation will happen. Now what will happen if 90-degree clockwise rotation is happening? So this will turn like this, right? So this part which I am highlighting right now, this anterior border will come towards which side? Right side, right? This anterior border will uh, come towards right side, right? So it will be rotated like this, and this posterior border, okay, this posterior border will come towards the left side, right? So if it is around the longitudinal axis, आगे की तरफ क्या था? आगे की तरफ यू ऑलरेडी नो इट इज द एंटीरियर बॉर्डर, और पीछे क्या था? पोस्टीरियर. अब रोटेशन हो रहा है, 90 डिग्री. सो एंटीरियर विल कम टुवर्ड्स द राइट एंड पोस्टीरियर विल गो टुवर्ड्स द लेफ्ट. So if it is around the longitudinal axis, now you already know the anterior border, okay, it will become right, okay, it will become right, okay, and it becomes right, and it is towards which region? You already know it is the right, and this is the left part, right? So the anterior border becomes right, and it is nothing but the lesser curvature, right? The lesser curvature is towards the right, right? So see how it happens. And you already know the posterior border, now this posterior border towards the greater curvature, okay, this posterior border will come towards the left, okay, and this is one which will form the greater curvature, right? And what will happen to the right and the left surface? The right वाला जो surface है वो पीछे चला जाएगा, ठीक है? The right surface will go towards the back. So the right part, okay, the right surface, it will form the posterior surface, right? और ये जो लेफ्ट वाला सरफेस है इस साइड वाला वो आगे की तरफ आ जाएगा, राइट? सो द लेफ्ट सरफेस विल फॉर्म द एंटीरियर सरफेस. तो बहुत सिंपल है, यू ऑलरेडी नो कि आगे की तरफ क्या है? एंटीरियर बॉर्डर, पीछे क्या है? पोस्टीरियर बॉर्डर, राइट? ओवर हियर वी हैव the right surface, and over here we have the left surface. After rotation, 90-degree rotation, this anterior part, okay, it will come to right will go behind, posterior ban jayega, this posterior border will come towards left, and this left surface will come towards right, I mean towards in front, that is the anterior surface, okay. So that's why yeah, you have to remember that the anterior border, okay, the anterior, it will be supplied by which vagus? इस side कौन सी vagus थी? That is the right. Now if the rotation it is happening in the transverse axis, right? If it is happening in the transverse axis, you already know, if the rotation it is happening in the transverse axis, now before the rotation, okay, before the rotation, the cranial end and the caudal end, right? The caudal end, both the end, they are in the same plane, right? They are in the median plane. If there will be a rotation, then what will happen? The cranial end will move towards the left, okay, the cranial end will move towards the left, right? The cranial end, it will move towards right, the cranial end will move towards the left, okay, and slightly inferior, and the caudal end, it basically move towards the left and slightly superior, right? So you can see over here we have the stomach, right? You can see the lesser curvature which is on the right side and the greater curvature which is on the left side. So this is about the development of the stomach. Now let us discuss the mesentery also over here. Now you already know. Let me just show you with the help of a diagram first. Yeah. So let us suppose this is the anterior abdominal wall and this is the posterior abdominal wall. एक वॉल आगे की तरफ है एंटीरियर एब्डोमिनल वॉल और एक वॉल पीछे की तरफ है दैट इज द पोस्टीरियर एब्डोमिनल वॉल. ओके, in between you already know what is developing. The stomach is developing, right? The stomach is developing in between. So let us mark this as the developing stomach. So this you already know, this is the stomach. Now the stomach, it is suspended with mesentery. The mesoderm actually it is surrounding it. Okay, in the anterior part, okay, in the anterior part it is connected to, okay, the anterior abdominal wall with the help of the ventral mesentery. Okay, it is suspended to the anterior abdominal wall with the help of this ventral mesentery or mesogastrium, and it is also suspended to the posterior abdominal wall with the help of the dorsal mesentery. We have the dorsal mesentery over here, right? With the dorsal mesentery. Now, in the ventral mesentery, what is developing? Liver is developing. So let us mark the liver, right? Let us mark this as the liver. So this is the developing liver over here, right? Now the mesentery. Now everything it is the ventral mesentery, no, in front of the stomach. The mesentery which is connecting the liver, this mesentery which is connecting the liver to the anterior abdominal wall, this is called as the falciform ligament, right? It is developing into falciform ligament, right? And the mesentery which is connecting the liver to the anterior to the lesser curvature of the stomach, this is called as, yes, this is called as the the lesser omentum. It is called as the lesser omentum, right? It is called as the lesser omentum. Now if I ask you, lesser omentum and falciform ligament, they both are developing in which mesentery? Ventral mesentery only, right? As the liver. Now in the dorsal mesentery, you already know an organ is developing over here. Yes, that is called as the kidney, right? Repeat. Now in the dorsal mesentery, you already know an organ is developing over here and that is called as the spleen, right? So if I just want to, okay, this is, let us suppose this is the spleen and the mesentery which is connecting the spleen to the greater curvature of the stomach, yes, this is called as the splenogastric ligament. Splenogastric ligament. Splenogastric ligament. And you already know, or the gastrosplenic ligament. Repeating the last word again. It is also called as the gastrosplenic ligament, right? And the mesentery which is connecting the spleen On the posterior abdominal wall, you already know the kidneys are developing. The kidneys are developing. Now, the mesentery which is connecting the spleen to the kidney, it is called as the lino-renal ligament. Now, let me show this through a cross section over here. Let me take a cross section over here. I'm cutting this and I will now try to show you what is there, right? Let us suppose this is the anterior side and let us suppose this is the posterior side, the posterior abdominal wall. Anterior abdominal wall and the posterior abdominal wall, and in between you already know we have the developing stomach. So stomach we have drawn with red color. So let us just draw this stomach over here. Yes, this is the stomach, right? Now, if you are taking a cross section, you already know we have the ventral mesentery, which is helping to connect the stomach to the anterior abdominal wall, and we have the dorsal mesentery, which is helping the stomach to connect to the posterior abdominal wall, right? So let us just draw this. So in the ventral mesentery, you can find that the liver is developing. Okay, the liver is developing. Let us suppose this is the liver, right? And this hole that I am highlighting with the yellow color, it is the ventral mesentery. Right, this is the ventral mesentery. In the ventral mesogastrium, the liver is developing. It is the septum transversum, right? So this is the ventral mesogastrium, in which the liver is developing. Now, ventral mesogastrium will have two parts, right? Ventral part and the dorsal part. एक जो liver के आगे वो बहुत ही anterior हो गया. So this will be called as the ventral part of the ventral mesogastrium, and we will have the dorsal part of the ventral mesogastrium, right? The ventral part will have which ligament, beta? I've already told you the ventral part will have falciform ligament. Falciform ligament, okay, which is connecting the liver to the anterior abdominal wall. The ligament which is connecting the liver to the stomach, okay, the liver to the stomach, it is called as the lesser omentum. Lesser omentum, right? So you can see the ventral mesogastrium has two parts, the ventral and the dorsal part, right? One which is connecting the liver to the anterior abdominal wall, that is the falciform ligament, and the other one, it is the dorsal part which is connecting the liver to the stomach, that is the lesser omentum. Lesser omentum. Now, on the posterior abdominal wall, right, on the left side, if you can see, a structure is developing that is called as the spleen, right? Let me just draw the spleen over here, right? Now let us suppose this is the spleen on the, yes, that is the spleen, right? So that is the left side, right? Now you already know it is the left layer of, it is the left layer, okay, of the dorsal mesogastrium, where the spleen is developing. So yes, if you just want to highlight this, you can highlight this. This is the mesogastrium and this is the dorsal mesogastrium, right? This is the dorsal mesogastrium. Now, the ventral mesogastrium, okay, now this dorsal part, okay, the dorsal part will also have two, okay, the dorsal part will also have two parts, right? The one which is connecting to the stomach, it is the greater omentum, right? The ventral part, we will have the ventral part, and we will have the dorsal part of the dorsal mesogastrium. Dorsal mesogastrium also has two parts. the ventral part and the dorsal part. The ventral part will have the greater curvature of the stomach. It has the greater omentum, right? Then we have the one which is connecting the stomach to this spleen. It is called as the gastrosplenic ligament, right? It is the gastrosplenic ligament, and the spleen, it is connected to the kidney on the dorsal mesogastrium by leno-renal ligament. Leno-renal ligament. So that is about the important, I would say, very important about the relations of the ligaments, like the relations of the ligaments with the stomach, right? So that is again very important. Now let's discuss a clinical case related to this. Let's discuss a clinical case related to this, that is called as the congenital hypertrophic pyloric stenosis. Now, this is also called as CHPS, congenital hypertrophic pyloric stenosis. Now, remember that it is more common in males, right, than females. The ratio, it is around 4:1. Okay, it is the first male, or like first born male child in the family, right? It is the first born male child in the family. Okay, it is associated with okay, write down, it is associated with maternal erythromycin intake during pregnancy. Okay, it is associated with maternal erythromycin intake during pregnancy. If the mother has consumed erythromycin during the pregnancy, so there are chances that the child can have congenital hypertrophic pyloric stenosis, right? Now, if there is hypertrophic in the pyloric muscle, okay, so there is abnormal hypertrophic pylorus musculature, right, और hypertrophic pyloric muscle. Pyloric muscle में hypertrophy हो गई है, okay, so what will happen? There will be gastric outlet obstruction, okay, so there will be, कोई भी चीज बाहर नहीं जा पाएगी, ल्यूमेन बहुत कम हो जाएगा, so what will happen? There will be functional gastric outlet obstruction, functional gastric outlet obstruction. Okay, now what are the clinical features that will be associated over here? The patient is actually normal at birth. The patient or the child, I would say, it is normal at birth. Okay, at birth nothing will be there. Okay, no vomiting is present at birth. There will be no vomiting at birth, right? Now, this helps us in differentiating between duodenal atresia. Duodenal atresia में क्या था? Vomiting is present since birth and we have bilious vomiting. Over here, the child, it is normal at birth. The symptoms, they will appear after 2 to 3 weeks, right? They will appear after 2 to 3 weeks. They will appear after 2 to 3 weeks. The vomiting will be projectile, right? It will be a non-bilious vomiting, and it is the child will suffer, or it is like in case of protein energy malnutrition. Repeating the last line again, last line को cut कर देना. So in this case, basically the child is not having any protein energy malnutrition, right? So yeah, coming on to the diagnosis, remember ultrasound abdomen. If we do an ultrasound abdomen, what you will see, there will be hypertrophied pylorus, right? The pylorus muscle is hypertrophied. Okay, the investigation of choice, it is again this ultrasound abdomen only, right? Now remember the thickness. When we say hypertrophied pylorus, so you should remember the thickness of the pylorus musculature. The thickness of the pylorus musculature, if it is more than 4 millimeter, or if the length of the pylorus musculature, okay, if it is more than 16 mm, right? If it is more than 16 mm, on X-ray you will get a single bubble sign. Okay, you will get a single bubble sign over here. If you can see, if there is a pylorus hypertrophic pyloric muscle over here, hypertrophic pyloric muscle, what you will get? You will get a single bubble over here. Single bubble sign will be C. Single bubble sign will be C. Over here, because of gastric outlet obstruction, now what will be seen? Typical metabolic alkalosis will be seen, right? Typical metabolic alkalosis will be seen with paradoxical aciduria. Now if you see, if suppose this is the HCl, right? HCl is coming out. HCl is coming out. So what is, there is vomiting. What will happen now? There will be hypo. बॉडी के अंदर तो क्लोरीन कम हो जाएगा, hypoCl, and there will be hypopotassium. You already know there will be decrease in H plus and decrease in chlorine minus, right? So decrease in H plus itself indicates that there is metabolic alkalosis, right? Metabolic alkalosis has occurred. So it will undergo renal compensation, right? Renal compensation will be there, right? Now what these renal will do, they will start secreting HCO3, that is bicarbonate, in the urine, right? After some time, what will happen? There will be hyponatremia in the body. Hyponatremia in body, right? You already know the H plus is moving out, and the renal compensation starts. And this renal compensation, basically what it will do, it will start secreting the bicarbonate ion to maintain the balance. And along with the bicarbonates, what will happen? Sodium ions will also get out. The sodium ions will also get excreted in the urine. After some time, there will be hyponatremia in the body. This hyponatremia, we have less amounts of sodium in the body now. What will happen? The RAS will get stimulated. The renin-angiotensin system will get stimulated. Okay. What will happen? This aldosterone will be activated, and it will actively take, okay, all the sodium in the collecting tubule, in the collecting duct, right? And as soon as the sodium comes in, the H plus or K plus will be, okay, compensatory K plus will be coming in the urine. It is the first is the K plus that will come in the urine, right? So now you can see that the body has developed hypokalemia, okay? Body has developed hypokalemia. Okay, and it also starts secreting H plus, so that is paradoxical aciduria. So now, best time, what is the best time to examine this child, right? The best time to examine this child, it is when the child is feeding, okay? When the child is feeding, right? So there will be visible peristalsis. There will be visible peristalsis going from left to right. Okay, there will be visible peristalsis going from left to right. Okay, there will be palpable olive shaped swelling, okay, in epigastrium. And remember, it is followed by projectile vomiting. If you palpate this olive shaped swelling, then it will be followed by projectile vomiting. So what is the management over here? The management that you have to remember, you have to first correct dehydration. You have to first correct dehydration, right? First correct dehydration and metabolic abnormality, right? The best fluid, it is 0.45%, right? Normal saline plus dextrose you can give plus KCl, plus KCl, right? See, KCl is only added when the renal function is resolved, okay? So just to assure the renal function, right, then only KCl is added, right? Or simply you can give ringer lactate, okay? And the surgery which you can do, it is Ramstead pyloromyotomy, okay, just to cut this particular muscle, okay, and excise it off. So that is about the congenital hypertrophic pyloric stenosis. Thank you.